Hello again, everyone. So we are back again. So we'll be starting with bone tumors in this session. And first and foremost, I'd like to start today with Ewing sarcoma. So I will go with some history. Okay, I'll go with some history, and then we will talk about the presentation of Ewing sarcoma and different other clinical features of Ewing sarcoma. And then we will move on to different other tumors. So for today's session, I've kept Ewing's, I've kept osteochondroma, bone cyst, metastasis to the bone, and enchondroma. So, moreover, we'll be covering other topics also certainly. So, let's start with Ewing's. So, presentation for Ewing sarcoma is a 10-year-old boy because it's one of the most common tumor in the first decade of life. Okay, so I'd like to say you that Ewing sarcoma is it's a diaphyseal tumor, and again, in the diaphyseal tumor, you should not forget Ewing sarcoma and osteoid osteoma, the most important diaphyseal tumor. Of course, there are other tumors also, like we'll talk about that certainly, but major one being two. One is osteoid osteoma and other one is Ewing sarcoma. How are they different? Osteoid osteoma comes with the presentation of a nidus, and there is actually relief of pain after taking prostaglandin inhibitors, that is basically aspirin or any kinds of NSAIDs, okay, in the case of osteoid osteoma. Whereas in the case of Ewing sarcoma, the presentation is somewhat similar to that of your infections. So a 10-year-old boy comes to the Department of Orthopedics with severe pain in the thigh with fever feeling, and on investigation there is raised ESR, and this shows a picture of infections, but on ruling out it's a tumor. What's the tumor? Yes, it is Ewing sarcoma. So it's a highly malignant tumor. It occurs in 10 to 20 years of age, sometimes up to 30 years of age. Okay, so it's the pathologically the bone affected commonly occurs in the long bones. Basically, your long bones also it occurs in the diaphysis. Okay, so usually the metadiaphyseal or diaphyseal of the long bone, but may occur at any site. But the major one is diaphysis. So the most common one, you need to know the most common one, right? So the most common one is the diaphysis. So if I say you that there is a tumor in the diaphysis and it's a malignant tumor, the first thing that should come into mind is Ewing's. So if you look into the gross pathology of Ewing sarcoma, it involves a rare area, even entire medullary canal, gray-white in color, may be soft, thin, almost like a pus. See here, this word, like a pus. In my first word, I told you that it resembles like an infections, right? Similarly, radiologically also you can see the infectious pattern. What you can see in radiology, whenever there is a infectious pattern, you might be thinking of somewhat which like some haziness type of pattern, which is basically a sequestra. Sequestra looks a bit hazy, right? So you might see that particular picture, and you might have a confusion that whether there's an infection. But the things comes out to be clear whenever you take a biopsy. So if you go for a biopsy, what you see is you will see particularly rosettes in the case of rosettes, okay, in the case of your Ewing sarcoma. And what other features in Ewing sarcoma? See, Ewing sarcoma is a primitive neuroectodermal tumor. In your eyes, it is retinoblastoma, and in its brain, it's your medulloblastoma. So these three primitive neuroectodermal tumor must be ruled out, okay? So bone may be expanded and the periosteum may be elevated with subperiosteal new bone formation, often in layers. So it's basically saying you that there is a periosteal reaction. Periosteal reaction is actually a reaction that is shown by a body, by the host body, to actually prevent the seeding of the infection or to actually prevent the seeding of the tumor to distant other sites. But what happens is the tumor or the infections become so aggressive that the periosteal reaction can't be that effective, because of which there is actually severe periosteal reaction, and that reaction in this Ewing's looks like an onion ring pattern. It looks like an onion ring pattern. Onion ring pattern in your ear, it is keratosis obturans. Okay, so correlation is important. In your ear, it is keratosis obturans, onion ring pattern. Again, in your bone, in your radiology, it is your Ewing sarcoma. Now let's talk about the tumor ruptures into the cortex early and extends into the soft tissues. Of course, it's a malignant tumor, so it can go to the soft tissues and it can involve the soft tissues, right? Histologically, I already told you that you can see that beautiful rosettes over here. It looks like a rose, right? Okay, it looks like a rose. So you can see that there are beautiful rosettes that you can see here. And these are resembling lymphocytes with very little intracellular matrix. Okay, very little intracellular matrix. Okay. So 10 to 20 years, pain and swelling may be history of trauma. Yes, there might be history of trauma. You might be thinking that there might be a fracture associated infection. But no, it will be a tumor. Okay. Maybe fever may be there, confused with osteomyelitis. On examination, swelling is located in the diaphysis and erythema may be present. You can see how beautifully the swelling has been shown over here, right? Now this is towards the knee region, but it is towards the diaphysis, okay, usually towards the diaphysis. So onion peel periosteal reaction, classical hallmark feature of radiological feature. But the diagnostic of choice, like the confirmation, is by histology, okay. Lytic lesions in the medullary zone of the midshaft of long bone with cortical destruction and new bone formation in layers, onion peel appearance. In atypical cases, it might be located in the metaphysis and may be confused with osteomyelitis. So, pictured. So, can you tell me the osteomyelitis? Osteomyelitis that occurs in the diaphysis. Okay, let me give you 5 seconds. 5, 4, 3, 2, 1. Okay, so this is salmonella. So any salmonella infection, salmonella typhi, it involves the diaphysis. So it's one of the MCQ questions. Okay, again, other investigations that we can do is actually we can go for an MRI. Okay, we can go for a bone scan. Okay, and we can go for a cytologic study. Very, very important. 1122 mutation, 2412 mutation. 1122 is very, very, very important. Okay, 1122. Remember, 922 was Philadelphia chromosome towards the leukemia. Okay, so this is 1122. Exactly, 1122 is 22. Okay, and 2412 exactly 2. 12 into 2 is 24. So 2412. Okay, do not write to 1222. It's 2412. Most common translocation, increase in the WBC count, ESR and CRPs. Differential diagnosis, of course, it is chronic osteomyelitis. It can be differentiated from it by sequestra, well-defined cloaca rather than smooth periosteal reaction, and located in the metaphysis. Okay, so sequestra like picture may be seen, but exactly sequestra is something different. Okay, critically picked up by the radiologist. Treatment, it is highly radiosensitive tumor. It said that Ewing sarcoma, whenever you give radiotherapy, it melts like an ice. Okay, it melts like an ice. The thing is, if you go for radiotherapy, there might be a chances of recurrence. Okay, you can go for a surgical excision also, but that depends upon the etiology, upon the factors. So there are different multi approach how you're going to treat the tumor. Highly radiosensitive tumor but recurs because of radiology. Okay, it melts like an ice. Treatment principle controls consist of control of local tumor by radiotherapy and control of metastasis by chemotherapy. So it's radio and chemo. Can you say me other tumor where we go for radio plus chemo? Yes, CA larynx, CA hypopharynx, correlating with your ENT. Vincristine, cyclophosphamide, and adriamycin in cycles repeated every 3 to 4 weeks for about 12 to 18 cycles. So it's okay if you just remember the names, vincristine and cyclophosphamide, two very, very important drugs. Can you write with me vincristine and cyclophosphamide? Vincristine and cyclophosphamide. Prognosis, it's poor prognosis. Bone to bone secondaries are very common. With improvement of potent chemotherapy, your survival increase up to 10 to 30%. Okay, so up to 30% we expect the survival rate. Now we come to multiple myeloma, next topic. But before going to multiple myeloma, I would like to revise Ewing sarcoma. Okay, anything missed from my notes we will revise. Okay, so Ewing sarcoma, it's most commonly seen in males. Ewing sarcoma, it's more commonly seen in males. Okay, it's a tumor of the first decade. Okay, it most commonly occurs in the second decade, but it's tumor of the first decade. So remember, if it's a girl with malignant tumor, it is giant cell tumor. But if it's a boy, malignant tumor, 10 years of age, first decade, it is Ewing sarcoma. Again, the major hint is resembling feature of acute infection like osteomyelitis. Poor prognostic feature if it has a metastasis, fever, leukocytosis, and if it is high in age. For example, if it has occurred in more than 12 years of age, the prognosis becomes bad. But even the actually Ewing sarcoma as a whole, the prognosis is bad. The tumor is malignant and the prognosis is bad. It's a diaphyseal tumor, or the diaphyseal tumor except for Ewing's, it's osteoid osteoma. How do you differentiate osteoid osteoma? It tends to relieve with the intake of NSAIDs or aspirin. Now, can present as infection, swelling in the middle of the thigh or leg, I know, and there is signs of inflammation, clinicals and labs can there, and then is incidental history of trauma. So you might be confused with a fracture. Please don't be. There is a tumor. Okay. So when aspirated, pus also comes out. Okay. So when aspirated, the pus comes out, but it's not pus. It's actually a tumor. Okay. And onion peel appearance is seen in the case of your radiology. In radiology, you will see onion peel appearance. Okay. In biopsy, you will see small blue round cells. Okay, which is known as pseudorosettes, and it resembles lymphocytes. Resembles lymphocytes. This word is important. Resembles lymphocytes. Next is, of course, I already told you 1122 mutation and 2412 mutation. 2412, 11, 22 mutation. There's also one more translocation, that is T2122. Okay, we already talked about here about the mutation 1122 24. I'm sorry, 1122 2412, and there is one more mutation which is 2122 also, and there is 722 also. Okay, so if you can remember, it's better. It's a neuroectodermal tumor, and CD99 is positive. CD99 is positive and pass positive. CD99 and pass positive. Ewing sarcoma, it arises from the endothelial cells of the bone marrow. Okay, it arises from the endothelial cells of bone marrow. Okay, or the primitive neuroectodermal tumor, I have already talked about this one. Okay, radiotherapy is usually avoided. Even though it melts like an ice, there is high chances of recurrence because of radiotherapy. Whenever you talk about the other treatments that you can go except for radiotherapy, is you can go for chemotherapy like vincristine, and vincristine like drugs you can give vincristine and cyclophosphamide. Okay, vincristine and cyclophosphamide like drug you can give. Okay, in cycles, you are giving this in cycles. Every 3 to 4 weeks you are going to repeat it to about 12 to 18 cycles. Okay, now you need to remember that there is we can also go for a limb salvage resection. Okay, we can also go for a limb salvage resection, and what you need to remember is vincristine and cisplatin and cyclophosphamide. Okay, cisplatin can also be used as a chemotherapy. Okay, and Ewing sarcoma is a radiosensitive tumor, and it smells like an ice. Okay, it melts like an ice. We have already told. Limb preservation surgery. The surgery that we can do for Ewing's is limb preservation surgery. Okay, limb preservation surgery. What we are going to do is we are going to use sometimes nowadays what's the pattern is. Remember that Ewing sarcoma, it can mets to lung. Okay, it can mets to lung. Ewing sarcoma is malignant tumor. It can mets to lung. Okay, and poor prognostic factor, I already told you: age, distant metastasis, tumor size, right? So we end Ewing sarcoma here. Okay, so I hope we are clear with Ewing sarcoma. Now let's talk about the next very important tumor, multiple myeloma. So what is multiple myeloma? Multiple myeloma is actually a tumor of it's a hematological tumor. It's a tumor of stem cells. Okay, what happens is basically your stem cells is not able to make certain, the bone marrow cells, melted neoplasm derived from the plasma cells. Okay, so what you see is actually a patient who is coming to you, maybe 50-60-year-old patient. Okay, and he has a feature that he has a complaint that in his urine during a routine investigation there was Bench zones protein. Okay, or you can also say that there is a spike in the gamma globulin. There might be a spike in the gamma globulin, or there might also be a history of certain other feature like anemia, recurrent infection, or maybe thrombocytopenia. Okay, recurrent bluish patches all over his body. And the picture, it resembles like, either this is an infection, because of course anemia or thrombocytopenia can also be seen in the case of malaria. It can also be seen in the case of dengue, right? Of course, he'll have other supporting features, like maybe he might have hepatosplenomegaly because of the improper red blood cells that has been formed. It might go and be destroyed, right? So it is very difficult to diagnose until and unless the Benzone's protein is there in your question, right? So let's talk about multiple myeloma. Malignant neoplasm, it is derived from the plasma cell, right? It may occur as solitary lesion, plasmacytoma, or multiple lesion, that is multiple myeloma. Okay. Histology, it appears as a seeds of plasma cells, okay, seeds of plasma cells, which are small, round blue cells with a clock face nuclei and abundant cytoplasm with a perinuclear clearing halo. What a beautiful histology. Now this histology is very important, and it's a classical hallmark for pathologists. That is why I'm repeating this again slowly. Histology, it appears as the seeds of plasma cells. So what are the plasma cells? They are the cells which tends to produce B cells, and then there is antibodies, right? So seeds of plasma cells, which are small round blue cells. See here, round small blue cells, okay, with a clock face nuclei. So you can see here, this nuclei looks like a clock face. The nuclei looks like a clock face. And abundant cytoplasm. Can you see the level, the amount of cytoplasm in this particular diagram? You can see that there is abundant cytoplasm. In contrast to Ewing sarcoma, there was little cytoplasm. But here there is abundant cytoplasm. You can see that this is the amount of cytoplasm for one cell. That means that is an abundant cytoplasm. With perinuclear clearing halo. What does that mean? That means around the nucleus it's totally clear. Around the nucleus is totally clear. Can you see? Around the nucleus is totally clear. This is known as perinuclear clearing halo. So one is perinuclear clearing halo. The second feature, very important, is the cell resembles clock face. Number two. Then the next feature that you need to understand is the histology. It appears like a sheath of plasma cells. It will appear like a sheath of plasma cells. Let's continue. Now let's talk about the grossly. It is a soft gray and friable tumor. Sites is the spine, which is the most common, followed by flat bones like pelvis, skulls, and ribs. Why flat bones? Because remember, whenever there is actually defective in the formation of these blood cells, it goes usually to the extramedullary hematopoiesis can be there, because of which the skull, the ribs will be most commonly affected. That is why, can you correlate in the case of your thalassemia also, there was medullary hematopoiesis, because of which there was cheekbone faces in thalassemia. Now in the case of multiple myeloma, it's also the same thing. The multipotent stem cells are now defective. There is no particular stem cells. Now I want the other areas of my bone to also become active. That is why first is the spine, the third one is the flat bones, pelvis, skulls, and ribs. Bone is replaced by tumor tissues, and there is no reactive new bone formation. Okay, all the bone is replaced by the tumor tissues. Usually affects male above 40 years of age. I already told you before the starting of this presentation that presentation of multiple myeloma is more than 40 to 50 years of age. Okay, bone pain is the most common complaint. Weakness, weight loss, anemia, thrombocytopenia, peripheral neuropathy, hypercalcemia. Why hypercalcemia? Why peripheral neuropathy? See, because of the extra amount of tumor cells in the bone, there might be an impingement of your nerves, because of which there will be peripheral neuropathy. Hypercalcemia, because hypercalcemia and then renal failure may be present at the time of diagnosis. Why hypercalcemia? Can you just correlate hypercalcemia? Of course, the remodeling of the bone will be high in this case, right? There is excessive remodeling. Because of excessive remodeling, there will be hypercalcemia and renal failure. Of course, hypercalcemia that may be associated with hypercalciuria may eventually go for urine failure, or because of the transfer of Benzone's protein through the urine, there might be a renal failure. Okay. We will talk about that certainly. Pathological fractures are relatively common. Of course, it is involving the bone. The bone is full of tumor cells. Of course, the tumor cells make the bone weak, because of which there will be fractures. If there will be fractures, there will be release of fat globules in the urine. Fat globules in the circulation. There are a lot of things. So multiple punched out lesions. Excellent. This is the most important thing that you should say. Okay, punched out lesions that is seen in the skulls. Okay, so multiple punched out lesion that is seen in the skull. Okay, punched out lesion in the skull and other flat bones which are purely lytic without any surrounding area of sclerosis. There is no sclerosis. There is just a lytic mechanism. Lytic. Okay, from this word it's so clear, purely lytic, no sclerosis. What does that mean? Continuously the bone is being eaten up. Continuously the bone is being eaten up. Of course there will be hypercalcemia, right? Pathological wedge collapse of the vertebrae, usually more than one in the thoracic spine. We already talked that the most common site being the spine, and in the spine also what happens is, because of excessive collapse, there'll be wedge sepet collapse. You know that in your tuberculosis also there was a wedge sepet collapse. In your scoliosis also there was a wedge sepet defect, right? So in the spine, mostly, moreover, there is a wedge sepet defect. Okay, diffuse and severe rarefaction of bones. Of course there is remodeling. Rarefaction means it is seen in also in the case of osteomalacia, so you can correlate from there. When there is excessive removal of the calcium from the bone, there will be an area of rarefaction, isn't it? So in the blood there will be low hemoglobin, there will be high ESR, inflammatory activity is so high, increasing the total serum protein. Total protein will be increased. AG ratio reversed. Okay, why reversed? Gamma globulin spike. There's a gamma globulin spike, because of which the gamma globulin will be more now. That is why reverse. Okay, increase in the serum calcium, normal ALP. Okay, urine there will be Benz-Jones protein. Benz-Jones protein in 30% of the cases. Serum electrophoresis, it shows a spike. Serum electrophoresis, it shows an abnormal spike in the gamma globulin. Okay, bone scan is required in solitary lesion. What is the treatment? Treatment is, go for a best treatment will be bone marrow transplantation, but other treatment also we have to write. Okay, primary treatment is chemotherapy. Symptomatic bone lesions usually responds to radiotherapy, chemotherapy. Okay, pathological fractures may be prevented by splinting. Pathological fractures may be treated by conservative or operative method. Okay, Milfalin is the drug of choice. Milfalin, new drug. I also listened it in the first time. Milfalin is the drug of choice, given in combination with vincristine, prednisolone, and sometimes with cyclophosphamide. Cycles repeated every 3 to 4 weeks for at least 6 to 12 cycles. There it was at least 18 cycles. Here 6 to 12 cycles. Ewing sarcoma 18 cycles. This is to metastasis to the bone. This is a new topic. So now let's revise on multiple myeloma from our notes. So multiple myeloma, we have already talked that this is derived from the plasma cells. It involves the flat bones like pelvis, skull, vertebrae. It might be a solitary lesion or it might be a multiple lesion, as I already talked in the first slide. It is a small circumscribed lesion. There is abundant amount of cytoplasm. Okay, bone is replaced by the tumor tissues, because of which there will be high chance of fracture. High chance of fracture. Grossly, it is soft, grey and friable. Microscopically, what you can see is, you can see perinuclear halo. Please write it down. Perinuclear halo, cells resembling cytoplasm, cells resembling lymphocytes, abundant cytoplasm. Adults more than 40 years of age are more common. Men are more common. Multiple size involved. Increased severe pain in lumbar and thoracic spine. Pathological fracture may be there, because of which there will be wedge sepet defect. Severe weight loss will be there. Neurological symptoms when the tumor presses on the spinal cord. Local tenderness over the affected bone. Punched out lesion will be seen. Okay, in the skull. Wedge sepet collapse will be seen. Thoracic spine is basically involved. Okay, and the borders of the ribs are eroded. Of course, there will be rarefaction because of osteomalacia. We have already talked about osteomalacia. will be there. Increase in ESR, HB is down. Increase in the calcium because bone is being resolved. Because of the bone is being resolved, there is a rarefaction. Okay, ALP will be high if in case there is bone resorption also, bone formation also. If this both activity will be there, ALP will be high. Okay, like in the case of Paget's disease, but here it is not that case. It is just the bone resorption. That is why ALP will be normal. Okay, increase in the total protein, albumin to globulin ratio is reversed. Okay, increase in the serum calcium, AG ratio is reversed. Benzone's protein, serum electrophoresis, abnormal spike in the region of the gamma globulin. And if you talk about the biopsy, like bone biopsy, if you done, you can see myeloma cells are seen. Okay, and you can go for the iliac crest biopsy. Okay, iliac crest biopsy, you can go for bone scan or PET CT. Control of the tumor by chemotherapy. Splinters of the disease part is done to prevent the fracture. Okay, radiotherapy, neurological compression, localized painful site of lesion. There's a triple drug regimen. Okay, triple drug regimen, but the bone marrow transplant can be done. Okay, and for chemotherapy,